All right. Pericardial disease, okay? The pericardium is a double sac that covers the heart, okay? It's not a single sac. It's actually a double layered sac, okay? And inside this sac, you have this pericardial fluid that acts like an ultrafiltrate plasma, okay? It does not have any proteins in it normally, okay? So it does not have any of the coagulation factors. So as a consequence, if you have any fluid that develops in there, it doesn't clot, okay, which is very important. Normally it's around 20 to 25 cc's in there. The reason that volume's in there is it acts like a lubricant to help when the heart beats and it rotates inside the pericardium that it doesn't stick and attach to anything. So it helps the heart basically freely float. Just like when you see a piston in a car work, you have oil. The oil basically prevents the piston from touching metal to metal and makes the piston more efficient. Okay? It does isolate the heart from the surrounding structures, importantly, and it prevents adhesions. And the normal intrapericardial pressure follows the thoracic pressures. So in other words, what that statement is saying that if I increase my intrathoracic pressure by positive pressure, then that's also going to directly affect the intrapericardial pressure. Cardiac tamponade is one of those things that you can really hurt somebody if you don't know how to treat this. There's many causes of tamponade. Trauma, which we'll talk about later on. We'll talk about mechanisms that cause this. You can also see it from postoperative bleeding from cardiac surgery. You can also occur from perforation of the ventricles, such as from pacemakers, placements. It could be iatrogenic or transthoracic, okay, which would mean a bullet wound. You can also significantly see this in malignant diseases where you get malignant pericardial effusions. When you actually draw the fluid out in a tamponade or a pericardial effusion, you can tell that it's cancer almost immediately because instead of it being like a straw-colored fluid, it'll come out as serosanguinous. That's never a good sign when you see bloody pericardial fluid. Usually it means either the person's hemorrhaging or it's got that slightly light blue, that light red color to it. Usually it's malignant. Okay? And also in chronic renal failure, you can also get significant development of pericardial effusions that can be very, very large, of 300 to 500 cc's, which is normally people become symptomatic with a change of 25 to 50 cc's in an acute setting. So it doesn't take much to increase it to cause problems. But in somebody who's got chronic dilation, you can have a lot of volume in there. This would be the kind of an acute setting. This is what we actually do in the trauma bay every once in a while. If you have somebody have a gunshot wound to their chest or a stab wound to their chest, we'll actually open them up directly in the ER and then transport them after we got them stabilized. This is not a good sign, obviously, because it's a pathological specimen. So it shows you the clots all the way around the heart. The pathophysiology of cardiac tamponade depends on the onset time and depends on the volume. Okay? The faster, the less amount of time, the less amount of volume you need. The more time there is, then the more the actual pericardial sac will dilate, so you actually will have a significant amount of volume. Okay? This is the differences in the compliance curves, which I thought was kind of helpful to look at. Okay? You can see in a rapid onset effusion, as soon as you change the volume just a little bit, you get a rapid change in pressure, which then basically impedes both the left and right ventricle from adequately filling. Okay? This disease process is mostly a right ventricular failure, okay? Because the right ventricle is more distensible. Okay? It's also is more compressible as well than the left ventricle. Okay? So when you have cardiac tamponade, the right ventricle collapses first, which then impedes left ventricle from getting volume. But really the first portion of the heart that starts to collapse is the right ventricle. Okay? It's not that you don't have, it's a preload problem, it's rather a lack of preload in the heart, that you can't get it in the heart. If you look at the pericardial effusion that's chronic, you can see that the compliance curve becomes flatter. It has increased compliance, and as a consequence, it does not have this tamponade increase in pressure until later. Yes? Okay. Somebody who has a rapid effusion, okay? Okay, if you look at the XY plane, sorry, this is a little bit off the scale here, but the X in this case is volume over time, okay? And this one's pressure, okay? In this situation where you have a rapid effusion, a small change in volume leads to a big change in pressure. So patients that have an acute setting don't require a lot of volume changes to take place before the pressure builds up and causes cardiac tamponade physiology. If you have somebody who's in a chronic state, the volume will be much larger before you see a pressure change. Okay, so it takes a lot longer for it to take place. And you can see somebody in renal failure, you can see them accumulate pericardial effusion up to 6 to 8 months, and that's why you can see as much as 300 to 400 cc's of volume in there at times, which is rather impressive when you do it. Okay. The pathophysiology is the important part of it, is it increases fluid between the pericardium and the heart. This leads to an increase in compression of the heart, and it decreases the venous return. Okay? It does decrease both the left ventricular and right ventricular end diastolic volume. Okay? It's specifically more the right than the left, and it reduces the stroke volume, reduces the cardiac output. Now here's what everybody tries to mess you up with in exams. Okay? Even though there's lower volume inside the ventricles, the actual CVP and the PA occlusion pressure are actually going up. Okay? So CVP and PA occlusion pressure are both rising in that situation. Okay? The reason that's happening is because both are reflecting the intraventricular pressures. Okay? The intraventricular pressures in this situation are rising even though the volume's emptying. Okay? Now, what you see and what causes death in these people and what you'll hear about is that they'll tell you, look, you know, when you pick it up, the tamponade is that the CVP and the PA occlusion pressures are approaching your systolic pressure as well as your PA pressures. So what happens in this kind of situation is your PA and your systolic pressures begin to drop. Why are they beginning to drop? No volume ejection, right? So you have no ejection of volume into the pulmonary or systemic side of the aorta. Okay, so the systolic pressures in both the PA and the systolic pressure in the aorta begin to fall. Okay, but what's increasing is your CVP and your PA occlusion pressure are rising, and the PA occlusion pressure is reflected in the PAD. So the PA diastolic pressure is rising on you as well. Okay, so what you'll see is eventually they reach where the CVP, the PA occlusion pressure, and the PA pressures almost touch each other, and the same thing happens with the systolic pressures. So you see what's called an equilibration across the board. When they actually equilibrate, heart stops, game's over. Okay? As a consequence to this drop in cardiac output, the adrenal system kicks in maximally. Okay? The adrenal medulla starts to release heavy doses of norepinephrine and epinephrine at an inappropriate level, in the sense that it causes such intense vasoconstriction that you begin to lose essential organs like the kidney, and you'll lose blood flow towards the periphery. So one of the things that I find right away is I shake these people's hands, or I hold their hand real quick in my hand. And that'll tell me how bad the tamponade is. Okay? If I have real bad tamponade, when I hold the guy's hand, his hand will be cold. That's called cold shock. That's bad news. Okay? Cold shock indicates that the central system is now the only thing that's keeping that person alive. So all the blood is being diverted to the brain and to what the heart is. That's it. Everything else is being lost. Okay? So when you put that person to sleep, they're at much higher risk of falling apart on you than somebody who's got shock symptoms of pericardial effusion, but their hands are still warm. The sympathetics haven't still cranked up so hard that now you're not perfusing the extremities. Okay? Tachycardia is what's keeping these persons alive. They really can't increase their stroke volume because they have so much compression of the ventricle. So this is like a kid where you have fixed stroke volume. You cannot get any better stroke volume. So tachycardia is something you don't want to go away. So giving the esmolol to this patient will kill them very effectively. Okay? This is one of those difficult ones where you actually, if you have a acute pericardial effusion, okay, with tamponade, and you have an aortic tear, what do? The primary one that's going to kill you is not so much the aortic tear. That can still kill you, yes, but what's going to kill you is the tamponade. So you got to prioritize which one's going to hurt you more. So trying to decrease the heart rate in somebody who's got aortic tear, yes, you want to do that, but if you have significant pericardial tamponade, you can't, because you'll kill the patient before you even start. So don't slow down the heart rate in that situation. You're sort of stuck. Okay? If anybody comes to ask you and says, well, you know, you didn't slow down the heart rate and that's why the aorta tore, you go, well, you know what? I had the choice between a tamponade and an aortic tear. I took the tamponade, which is much more severe. And if I slowed that guy's heart rate down, fixed stroke volume, the guy's dead. So either way, sometimes you've got no place to run. You do the best you can. Okay? And trust me, in the OR, you're going to find out that I'm actually giving you pretty good stories about what's happened to me, but something will happen to you like that. You'll find out that you'll be between a rock and a hard place. Always do the best you can, and when you go home that night, say you did the best you can. If you want to read about it some more, but never beat yourself up over it. It says you've done the best you can in the situation you're in. Yes? Yes. Yes. If you can, I would bump it up to around 100 heart rate, because that's the only thing that's going to get you out of the trouble you're in for temporary. It's a temporizing measure. What you need to do is you need to go to the operating room. You need to drain this fluid through the pericardial window on this guy. You get eventual drop in blood pressure. That's usually a bad sign, even though the sympathetics are kicking up. Okay, that usually means that your stroke volume has now become significantly impaired, and your cardiac output is now dropping. So you're on the end portion now of this person's life, and myocardial ischemia may also occur because of the drop in diastolic pressure. What's happening in this person is that you have a dual effect. Coronary perfusion pressure is actually significantly impaired in patients with this kind of disease process, because you're increasing your left ventricular end diastolic pressure and you're decreasing your diastolic pressure. Okay? So ADP is falling and left ventricular diastolic pressure is rising. So that puts you at risk for coronary perfusion pressure issues, and you may develop ischemia. Okay? This is a nice showing you right atrial tracing, okay, and the aortic tracing. Okay? There's a huge fluctuation in here, okay, as you can see. Okay? This person is ventilating, but every time the person fires the ventilator, okay, you see this acute drop in pressure. This is somebody who's intubated, okay? So that's not normal, okay? Normally when you give positive pressure to a person, you should see a rise in pressures initially, because what you're doing is you're helping empty the ventricle out, especially the left ventricle. So initially you just see a rise, and then you see a fall. And instead, this person, almost as soon as inspiration occurs, the pressure drops like a rock. Okay, that means there's really no more effective stroke volume left. So you get this kind of abnormal pattern. Okay. Now, when you do an echocardiogram, by far it's the best way to diagnose this. Okay. You can also get symptoms like dyspnea, diaphoresis. These people's minute ventilation is very high. Peripheral vasoconstriction may take place enough that you'll lose your pulse oximetry, which will give you that cold shock symptomatology. Usually because it goes to the core. If you put it on the ear, you'll still get a pulse oximeter to work. Tachycardia is always evident, hypotension, and you get very distant heart sounds because the fluid is between you and the heart. So when you listen to that person, you almost hear no heart sounds. You can see this echo. This is the ventricular wall. This is the pericardial wall. And you see the blackness in here? That's fluid. Okay? So that's all pericardial effusion. That's a pretty impressive amount. This one's due to renal failure, so it has a lot of volume. Diagnosis of cardiac tamponade leads to sympathetic activation, elevated venous pressures. This is one of the easiest central lines you'll ever put in. You also will get a pulsus paradoxicus, which may be absent in some situations if you have ASD or left ventricular dysfunction. You get Kussmaul's venous sign, and you get equalization of the atrial filling pressures and your pulmonary end diastolic pressures, as well as your aortic diastolic pressures. Your diagnosis is your EKG will show what's called electrical alterans, okay, which means you get fluctuations from the axis because the actual heart's floating inside of this fluid, so it gives you this electrical activity change every time your heart beats. But still, the best diagnosis is by echocardiogram. The best treatment is definitive is percutaneous pericardiocentesis. Okay, you can do the subxiphoid approach or subcostal approach. If you're in somewhere where you don't have anybody to help you, this is going to be actually life-saving to somebody. So if you end up going into a combat situation, or you're going to end up being deployed somewhere, you might want to learn this technique. It's actually fairly simple to do. The risk of getting into this is that if you go too deep with your needle, you can actually lacerate the ventricle, hit a coronary vessel. There's some major complications associated with this. So, but at that point, you're sort of stuck between a rock and a hard place. And sometimes you can actually save somebody's life. Okay? I've done like 5 of these in my career. They're not fun to do. You're very nervous when you're doing it. Sometimes what we used to do is to put alligator clips on it. And as we would go in with a needle, the EKG would be monitored, and you see a flipping of the T when you approach the heart. That way you didn't touch it. And then that's when you drain it at that point. The risk of this is you can go in a little bit too lateral, and it causes pneumothorax as well. So, but the subxiphoid approach is by far the safer way of doing it, I think. Subcostal approach would get you more into the lung. So we tend to do a subxiphoid approach, which means you go right into the xiphoid process, 2 finger breaths down, okay, and you redirect the nipple, the needle towards the nipple at a 30-degree downward angle. So you're going like this, and you're pointing it towards the ipsilateral nipple to the heart. So, and you go in about that far. That's a long way to put a needle. Okay, when you first do it, you're shaking, because you're basically stabbing somebody almost to death. Okay, and when you're entering that far into somebody's body, it's something that you're not used to doing. When you hit it, you'll feel a resistance. The pericardial sac is pretty thick and heavy, and as soon as you pop it, you'll feel the fluid will pull out pretty quickly. Now here's the trick. You get an emesis basin. Try to keep this as sterile as possible, of course. Okay. Sometimes in emergency situations, they do what's called a splash and burn. You just drop betadine on the patient, and you just put your spinal needle in and drain this. But when you drain 50 cc's out only. Most people with 50 cc's, what do? That compliance curve is vertical. So just draining 50 cc's out should bring that pressure down pretty quickly. So that person should improve very quickly with 50 cc's. Okay? If it's when you drop your blood into the emesis basin, you should see that it doesn't clot. It take about 5 or 6 minutes. Just watch it. If you see it not clotting, then it's in the pericardial sac. If the person gets better, you're in the pericardial sac. Okay? I've seen one person we were doing this in, and he was a little bit too aggressive. He actually got into the left ventricle. Okay? And he kept pulling out blood, and every time he was pulling out the blood, the patient got worse. And I said to him, I said, dude, I think you're in the wrong place. Okay? Pull back the needle a little bit. Okay? He's like, how do you know I'm in the wrong place? I said, well, every time you drain another 50 cc's, our A-line goes away. So if you're emptying out the heart completely, it's not really a good idea. Okay? So he pulled back the needle, got into the other layer, and sure enough, we got symptoms improved significantly. And then we were able to take the patient back to the operating room and got a pericardial window done on him safely. The heart surgeon did get to look at the heart, and he said, yeah, you got a bruise here. You get to the ventricle, but it wasn't leaking. So they didn't have to do anything to left it alone. Okay? Most of the time when you put a needle into the heart is a pretty strong, thick muscle, so it'll close back up on itself. The left ventricle may not be as forgiving. The right ventricle may not be as forgiving as the left, because the right ventricle is pretty thick, so it'll seal itself. Okay. If you don't have that ability, or you don't really think you want to do something like this, and you only have temporizing measures, fluids is pretty high on your list. Give these people fluids. Okay. Even though they have elevated JVD and they look like they're going to go into failure from the right side, you need volume. There's not enough volume inside the heart. Okay. So give more volume. It's like right-sided heart failure that you're treating, basically. Okay. Administer catecholamines to increase the heart rate and blood pressure even more. Okay. You're just trying to temporize. You don't care about the other organs that are wiping out right now. Right now, you're just trying to protect the brain and the heart. That's all you got left for now. And correct the metabolic acidosis sometimes, but do it very gradually. Okay, if you're seeing somebody breathing 40 times a minute, and you give them bicarb, what happens to bicarb when it gets into your bloodstream? What's that compound? Carbonic acid, very good. So when you give bicarb to somebody, it shifts this way. You don't have to believe me. Don't. Actually, I wish you don't. Okay? I'll dare you. Let's put it that way, okay? Next time you go to the operating room, okay, and you see somebody needs bicarb, call your buddies in the room. You can do a little Dr. Nolan experiment, okay? You can get your bicarb, and you're going to watch your end-tidal CO2 when you administer it. If you're too aggressive, okay, you will suppress the heart, and it's something you don't want to do, okay? So one of the things that we were taught when we have to give bicarb to somebody is immediately put our face on that end-tidal CO2 and watch it, and then push the bicarb slowly, especially if you're giving it through a central line, because that bicarb directly goes into the heart. And rapid changes in pH in the heart is actually not good for the heart. It'll actually cause failure to develop. Okay, so you don't want to do that. Okay, so as you give the bicarb, that bicarb will immediately split, okay, into CO2 and water. Okay, so it's acting on the hydrogen ion right away, because it's basically looking at a fairly rapid reaction taking place. And that CO2 will be seen in your end-tidal CO2. Okay, you'll see the end-tidal CO2 increase. Do not let the end-tidal CO2 increase by more than 4. If you're starting to increase that by more than 4, you're starting to cause big rapid changes in pH in the bloodstream, and you can actually see that the blood pressure begins to fall and things don't look right. Okay, the heart now will be stunned for about 30 to 40 seconds, but then the acidosis will get better, and all of a sudden the heart will start pumping and be happier once again. The problem with it is that 30 seconds, if you have somebody with tamponade, 30 seconds is like an eternity for that heart, and that's not going to do very well. Okay, so be real careful about giving a bicarb to somebody for this. Okay, you're not really treating the metabolic acidosis. All you're doing is you're hiding the metabolic acidosis by giving bicarb. The metabolic acidosis is from lactic acidosis from anaerobic respiration. Yes? Yeah. It doesn't work most of the time. If you have an acidosis that you're treating for a reason, it might help if your epinephrine's not working. The reason you should give bicarb to somebody is if they are having significant pH changes and you're not seeing that your medications are responding. Okay? In that sense, it may work then to help the epinephrine to work. Okay? But if you have a new onset, person just fibrillates and you're actually shocking them and doing CPR, there's really no reason to give that person bicarb. Okay? Because they really hadn't developed the metabolic acidosis at that point. You actually may be doing them more harm than good, in the sense that if you give somebody too much bicarb, you're shifting the oxygen dissociation curve towards the left, and you're impeding the oxygen delivery to tissues. And then when the person reperfuses, now the brain can't get oxygen, and it doesn't make anything better at all. It makes it worse. Okay? So it depends. Everybody does different things, and I can tell you when I worked in the ICU, I went back and read all the literature from resuscitation. I mean, I went through 3 months of reading just resuscitation literature. It was amazing how different it was from the actual studies than what we actually do. Okay? One of the things that we found out by reading that was that the CPR on animals was much more effective the faster you went. Okay? The least amount of diastolic time, which meant that your heart rate was 180 to 160 beats per minute, is really the best way to get the diastolic pressure to rise and turns over the heart. Okay, so what we did was we we did a little experiment. We actually took our patients that were in our ICU, and if they rested, we went to a new modality, which was high velocity, 3 people doing CPR. The reason they didn't recommend that, I found out later, was that nobody can sustain it. You can't sustain it. In other words, you can't have one individual doing 180 beats per minute. It's almost impossible. But if you have 3 people that are really strong, it works. In our turnover rate, we actually would have A-lines in most of our patients. And we could tell it was working because the diastolic pressure would rise. And as soon as it hit 50, the heart would turn over. It was amazing. Okay? We went to internal medicine. We'd always go for the intubations for the internal medicine docs, and it was a different unit. So we went over there one time. It was a young person, 28, 30 years old. And we tried not to interfere the way they ran codes. You know, it's just political. So we intubated this kid. And he was a little older than me, so he wasn't a kid, but he was a young man. So we were watching them do CPR, and they were doing it real slow. You know, and I looked at my friend who was with me and said, you know what, let's do this. Just show them, you know. And we did it at 180 heartbeats, and you could see the face of horror in the docs. They looked at us like, what are you guys doing? You're going to kill the patient. The patient's dead, dude. Okay? You're not getting him back the way you're doing it. As soon as we did it, within 35 seconds of us doing it, the guy's heart turned over and he came back. Okay? Had they continued doing what they were doing, that guy would have been dead. Okay? Because the other thing they were doing too is they were doing hyperventilating the patient too, which also is very detrimental. So we stopped. We told the respiratory therapist, stop ventilating and let us do CPR for 30 seconds like this. And sure enough, the diastolic pressure kicked up to 50, and because he's young, he turned over right away. So they learned something new that day. The literature is going to go back and forth. You guys should be resuscitation experts if when you get time. I didn't have time till after I was finished my training. I was in my fellowship. That's when I did a lot of this reading. So you should read some of the literature. It's really interesting because it really gives you a different insight than the American Heart Association. I mean, they've done what they need to do to train majority of people, but it has some faults in it, and that's why things keep changing. Haven't you noticed that how many of you have had, how long ago did you get the American Heart Association CPR? I've done that over 20 years ago, okay? And ever since then, you know how many times they've changed it? At least 4 or 5 times they've changed the recommendations. Okay, so, you know, whatever. Okay. Good. Okay. So what are they saying to do now? I haven't read that one yet. Okay. Okay. Well, most people that drop dead in the field are from an arrhythmia. So it makes more sense to just to do CPR. On the other hand, if you have somebody who drops dead from an obstructive airway, let's say you have somebody who's eating food and has something stuck in their throat, doing CPR is not going to work. It won't. Because the reason they died was not because of arrhythmia, they died because of lack of oxygen. So you got to get that person's airway open. So again, the caveat is disease process is taking place. If you have an obstructive, make sure you remove the obstruction so you can put air into this person, and then you get 3 or 4 breaths in, and then do CPR, and then you get the person back. I would think that would work better than if you do CPR on somebody with no oxygen. It's not going to work. Okay? Yep. So everything's going to have a but. Okay? So make sure you do this little experiment when you get a chance. It'll enlighten you as to how acid-base reactions take place. You can actually get a real good learning curve in that day. You'll really learn how this stuff works. Management of this kind of situation is that general anesthesia can have severe detrimental effects. It can preload reduce the patient. It can also vasodilate you inappropriately. It also can give direct myocardial depression in a patient with already a depressed heart. And the positive pressure was really what kills you. Okay? Positive pressure with somebody with all the pericardial effusion already in place, and you squeeze real hard on that positive pressure bag, you're going to get all of a sudden no filling of the ventricle, and the heart will stop. And then game's over. Okay? This is one of the few cases where I tell you the surgeon must be in the room. He can't be next door doing something else. He must be in the room. You don't put a person to sleep with a pericardial effusion without the surgeon in the room. Because if something goes wrong, it's going to go wrong immediately. Okay? And you lose somebody's pulse, you've got 30 seconds to get in there and remove the fluid around the heart. Otherwise, you're starting increasing the risk of anoxic brain damage. Okay? Your brain starts dying in how many seconds after you stop ventilating, after you stop perfusion? 1 minute. That's not much time. Okay? If you stop all perfusion to the brain, in 1 minute the brain starts to die. Now, if you give an anesthetic induction agent, you may have around 2.5, 3 minutes, because what have you done? You've suppressed the brain cells. You've put them to sleep. Their basal metabolic rate has dropped. So in that situation, you've actually improved survival time. Okay? But if you look at survival times for the brain in somebody who's awake and who drops dead, they have 1 minute before the cells begin to die. So it's pretty quick. And survival time is it's different from reversible time. Irreversible cell death is in 3 to 4 minutes. Okay, so if you do CPR and you bring this patient back to get some perfusion going, then that's okay. You can do CPR all day long, and as long as you're perfusing somewhat the brain, the patient will be fine. Okay? But if no perfusion occurs for more than 4 minutes, the brain basically will be dead. At that point, the heart's still survivable. Heart survival is 5 minutes. So it's got a survival time that's 4 times that, so it's 20 minutes. So you can actually bring somebody back 20 minutes later with underperfusion, okay, and still have a live heart, but a very dead brain. And you guys have all seen that. You've seen people that have been coded in the field and come in and they don't wake up ever again, okay, because the survival time for the brain is very different than the survival time for the heart. So anyways, this is one of the things you don't want to sit there and have the surgeon be across the hall or somewhere else, or he says, I'm here, and he's not really here. He's actually in the garage. This is not where you put somebody to sleep. You've got to make sure the surgeon is in the room with his nice little white sclera looking at you. Okay? So you want to make sure that you see the blues of his eyes or the green of his eyes. If you get into trouble and the surgeon's not there, then you're going to be forced to do a pericardial centesis to get the person out of trouble. So it's something you may not want to do. Induction, this is a great induction with ketamine. Ketamine is a sympathomimetic. The only downside to it is if it's a chronic tamponade, you may actually induce the myocardial depressant effects of ketamine, but sometimes, most of the time, this is usually an acute setting, so ketamine is appropriate. It increases heart rate, okay, increases sympathetic discharge. Succinylcholine is very important because most of these people have full stomachs. Okay, the reason they have full stomachs is as soon as you go to an underperfused state, the stomach stops working. So even though you think that the person has had an NPO, they're still got a lot of acid in their stomach. You can actually get what's called Cushing's or Curling's ulcers from stress ulceration from low perfusion states in this kind of situation. So it's mostly Curling's ulcers. Limit positive pressure ventilation after you intubate. This is what at a time I tell you, do not put it on the patient on the ventilator. Squeeze that bag in your hand and do little puppy breaths. Okay, you're just giving enough oxygen to get in, not trying to get big positive pressure in the patient. As soon as the surgeon gets in there and opens up the chest and is able to expose the pericardium and empties it, then you can switch over to the ventilator. Okay? Your biggest problem at that point is when they open up the pericardial sac is that you can get an increased risk of developing what's called flash pulmonary edema. Okay? Why would you develop flash pulmonary edema? Is because all of a sudden all the preload return comes back that you've dumped in that patient, comes back to the right ventricle and it dumps it into the lung very quickly. So putting that person in, as soon as they open up the pericardial sac with positive pressure is actually a smart thing to do because then you're also trying to impair preload return at that point as well, which is now you have way too much preload in the periphery and it can flood the patient. Okay? Maintenance can be used, nitrous oxide, oxygen. Most of us use either some kind of volatile agent. Pancuronium and fentanyl combination works fine because it increases, maintains the same heart rate. Monitoring, use a central line and A line. Now, for acute pericarditis, which is the next step, is an acute inflammatory process. This is what I call the mucus phase of life. It's like somebody basically putting mucus all over your heart. Okay, it's pretty disgusting when you open up the heart. It looks like this snot all over it. It's very sticky, okay, too. And you see the surgeon they don't really like it. It's kind of disgusting, okay. The pericardium actually becomes heavily thickened because of that. It's an acute inflammatory process. And as a consequence, what you see is the patient will develop restrictive kind of disease over time. What causes acute pericarditis could be infectious, idiopathic. It could be also Dressler syndrome, which is a post-myocardial infarction phase. It could be a systemic disease such as rheumatoid arthritis. So you can imagine, nice airway, right? Okay. Lupus and scleroderma, all those increases risk for acute pericarditis. Oops. You can also get acute pericarditis from traumatic, metastatic, chronic renal failure, drugs, as well as radiation. Usually the patients come in with acute chest pain, exaggerated by inspiration, and it's also exaggerated by being in a supine position when you lay the person down. It can also radiate into the abdomen. Usually they have a low-grade fever, which is an inflammatory process, and they have signs of some kind of systolic ejection problem, which is why they get the sinus tachycardia. This basically happens is they get a restrictive disease that basically prevents the heart from actually adequately filling. So this is a pretty nasty process. You'll actually hear a friction rub, okay? It's just like hearing your hands rubbing together. It sounds just like that. It sounds like sandpaper rubbing against each other. You also will see ST segments that will really freak you out when you look at it. But what you have to worry about is because you'll see the ST segments in all the leads. Okay? The ST segment change will be elevated in all leads, which is inconsistent with ischemia most of the time. Okay? Treatment is, of course, anti-inflammatory drug, which is salicylates aspirin. Non-steroidals have also been used, like Toradol and corticosteroids. Use only if conventional therapy fails, because if you have an infectious disease process and you give that person corticosteroids, you're also immunosuppressing them, and you actually just made the infection just get worse. So you've got to be real careful with that. Pericardial effusions from acute pericarditis can be very severe, okay, and cause this hemoperitoneum pericardium to develop in tamponade. You can actually, if the disease sometimes in post-Dressler syndrome, which is post-infarct ischemia, you can actually rupture the ventricle, and that's a disastrous consequence usually. That can occur from induction, believe it or not. I saw that when I was a young resident. One of my friends was putting somebody to sleep, and as soon as we put the patient, they gave etomidate and succinylcholine, and they lost the pulse oximetry. The EKG was still normal. The end-tidal CO2 was absent when they intubated the patient. The attending said, you got the tube in the wrong hole. He says, no, I got the tube in the right hole. And they went back and forth. So the attending stepped in, pulled the tube out, and put a new one in. And when they ventilated again, they had no CO2. The tip that something was really bad was going on was pulse oximeter went away, and end-tidal CO2 went away. And the blood pressure also seemed to go away as well, too. When we tried to palpate for pulses, we couldn't feel anything. The surgeon came in, opened up the heart, and sure enough, the ventricle was actually ruptured in half. It wasn't really a tamponade, but it was actually a severe post-infarction rupture. So that can happen too. It was just leaking slowly, and then eventually just rupture on induction. The stress from being put to sleep is enough to rupture the ventricle. Post-cardiotomy syndrome can also occur from acute pericarditis after cardiac surgery. It could be infective or autoimmune. It's an initiating event. It's usually blunt or penetrating trauma. The pericardiotomy is the most common. It occurs in 10 to 40% of events. Okay. You get chronic constrictive pericarditis. If you don't treat this aggressively enough, it can become increasingly worse. It's just radiation therapy can do this as well. And you get this very heavy banding effect around the heart. The surgeons are really not happy when they have to take care of these patients. Okay. The diagnosis is that you get a banding effect and the right ventricular failure is much more prevalent. So that's the key, right ventricular failure, not left. Okay? Because again, it's the same problem as any kind of tamponade. The right ventricle collapses at a faster rate than the left, okay? Because it's more compliant. Okay? You get venous congestion and hepatosplenomegaly and ascites develops in these people. So now you got multiple problems in your hands while you're trying to take care of this person. These people are really, really sick when you have to take care of them. And the other thing that we'll go into is because the right ventricle begins to fail, the right atrium dilates, and that's where the SA node is at, and that's what tends to cause atrial fibrillation, atrial flutter to take place. And then you lose your atrial kick, and then you got really a bad symptomology develop. So what's interesting about this is that the only way to treat this is by actually removing the pericardium, but this is a nasty surgery, okay, because the pericardium is many times attached to the ventricle itself. It acts like a band around it. Okay? So the surgeon has to peel away the pericardial sac off the heart. Okay? This is a hard, long case. It'll take 3 to 4 hours to do a lot of times. And everything will be oozing. Sometimes you'll get into ventricular arrhythmia, so you have to shock the patient out of it. So you've got to be really ready to take care of these people. The downside to these cases is they don't get better. They get worse immediately afterwards. So none of these people get extubated. All these people go to the ICU intubated. So expect that. They get worse because you just peeled away something that was touching the heart, and the heart's not going to be real happy. You get an inflammatory process that takes place, so there's going to be more swelling in the heart. The heart will actually lose its contractility to a certain degree immediately post-op. So most of these people get worse the first day. It doesn't make the heart surgeons any happier because, of course, they're going to have to take care of these very critically ill patients for 3 to 5 days before you see any significant improvement. And it becomes very touch and go for the first 2 to 3 days. So it's a pretty scary thing to do. Yes? Pericardial window is actually a very simple procedure. It involves putting a hole in the pericardial sac and allowing the pericardial fluid to drain into the pleural space. And by doing that, you increase the surface area for reabsorption of that fluid. Okay? So it's just you're putting a little rectangular hole about that big, and then you drain it directly into the pericardial. Yeah, and then it goes away. Eventually, over time, it scars down and it closes back up, and by that point, the pericardial effusion usually has gone away for a reason, whatever started it. Okay. Maintenance for these people is induction is normally like any other heart surgery. These people tend to be critically ill and they tend to have full stomachs, so you all should be etomidate, succinylcholine, or ketamine, succinylcholine, intubate them. Maintenance is usually for volatile anesthetics, and then emergence, you keep them intubated and go to recovery, ICU. A lot of these people will require lots of drips and supports, so expect that.